I really enjoyed that panel, and it was interesting to hear so many people talk about so many of the same frustrations I have in my practice in so many other aspects of medicine. I love how much we talked about the team approach with medicine and collaborating between specialties. From a sports medicine standpoint, I have the luxury of practicing in a setting where we have a team psychiatrist, multiple team counselors, team physicians, team orthopedists, that we practice as a team taking care of our 600 patients. And that model would translate so well to the community. We just need buy-in from the powers that be. My slides I put together, a few weeks ago, but it was interesting last night before I was going to bed. I'm not a huge social media poster, but I've become quite the consumer from a news and medical literature standpoint, partially because the AMSSM, our kind of governing body, has really pushed this information sharing, journal posting platform globally. And we're seeing physical therapists, orthopedists, primary care for sports medicine physicians adding to this conversation on an international level and really pushing this idea of exercise as medicine for our patients. There were two points that came up on my timeline last night. The first one had me so excited. It was a post about all of the benefits from physical exercise as a treatment and the 20 to 30% reduction in all these chronic medical issues. And Scotland actually puts out their national physical activity plan for their entire country to make it a priority. And no sooner was I elated with that information than the next post was the Columbia News in South Carolina about the bike lanes they put in a week ago or 2 weeks ago to increase bike commuter traffic that got such an uproar from the community they've taken them out. It didn't even last a week. We need to do better in this country, and I think as providers, we're going to have to be the voice. We're going to have to be the ones that are honest with our patients about the role physical activity plays in their life, and we're going to have to be the voice to the powers that be, our leadership and government and medicine, trying to get these changes made to better take care of our patients from cradle to grave and giving them the tools to prevent chronic disease instead of treating so much chronic disease. I don't have any disclosures. Objectives we know. Sorry. So it's interesting when you put in physical activity in the olden days. This is not my PE class in school, but maybe familiar for some of you, I don't know. But it was a priority. Kids played, kids got outside, kids did things. We've put such this emphasis on testing and remove physical activity from our kids that by the time they get to us as an elderly population, we're fighting an uphill battle. I mean, this isn't what's happening anymore. We're now dealing with this in our youth. As our patients are becoming less and less active as they grow into adulthood, we're having to battle chronic diseases that could have been prevented from the very beginning. Although we're focusing today on exercise in the aging population, keep in mind how you can combat this at all ages of your patient population. Don't try and save everybody at the end. Let's see how much we can do on the front end to really improve long-term outcomes. When you look at the data in 2015, 8.5% of our world population were over the age of 65. This is increasing exponentially by an annual increase of 27 million. By 2030 and 2050, they're going to be 12 to 16% of our population. So these are patients we're going to continue to see the evolution of chronic disease, the evolution of needing to get our patients moving, and how to care for them as they get older. Especially as you heard all the changes we go through as women that impact our ability to stay physically active. I find it interesting if you look at the per capita healthcare spending globally. We are spending an astronomical amount of money per patient per capita compared to our counterparts. But what is this getting us? This recent study looked at 11 countries, that we're leading as far as spending in healthcare, we're at the bottom. So we're putting all this money in and not getting great results. What if we use those financial resources to improve lifestyle, the things we've all been talking about? And again, what we can do to lead the way is really from the ground level teaching our patients how important physical activity is as a medicine. As our patients age, unfortunately, there are a lot of changes that they're going to go through. And the things we're trying to do in keeping them moving is to combat all these changes. But we have to understand how we have to modify the recommendations we're making to them. They're seeing a decrease in muscle mass, muscle strength, power, endurance, that contraction velocity, their mitochondrial function, oxidative enzyme capacity. You're also dealing with, decreased aerobic capacity, cardiac contractility, maximal heart rate we have to adjust for, stroke volume, cardiac output, nerve conduction velocity, balance, decreased proprioception, gait velocity, gait stability, their insulin sensitivity is going down, their glucose tolerance is going down, their immune function is suppressed, bone mass, strength, density is affected, collagen cross-linking, the thinning of their cartilage, decreased elasticity. So we're trying to help prevent these changes from happening so rapidly, but we also need to take them into account as we're looking at the patient and trying to make exercise recommendations for them. We also have to deal with some increases, the increased arterial stiffness, myocardial stiffness, the changes in systolic and diastolic blood pressure, and that increase in visceral fat mass, total body fat, and the ability to accumulate intramuscular lipids goes way up. So you can see how if we have patients who start with all of these changes and then they're not taking care of themselves and you get in this vicious cycle and they're running down the hill like a snowball. I think we've all had a patient cross our path where whether it's a hip fracture or a little change just snowballed. All of these changes they were going through physiologically and they end up at the bottom of the hill, this big giant mound. We need to catch them before they get kicked over the edge as a snowball. So, end goal, it's a growing challenge. It's really going to be one everyone has to take on together, but it's making our older people physically active and functionally independent until the rest of their lives, which is a lot longer than it used to be. But if we set this goal and focus on it, I think it's something we can accomplish in the medical community. We need to tell our patients, if they stay sedentary as they get older, they're losing 20 to 40% of their muscle mass. That's a huge change in these patients. We're seeing a 6% decrease per decade loss of lean muscle mass. So all of your kids that are not out running around, that's when they're making bone, that's when they're accumulating lean muscle mass. You're seeing a 20 to 30-year-old population right now that's kind of doughy. They might be thin, but they're not strong. They don't have good cores. They didn't develop that lean muscle mass because we didn't have them out playing, running around, doing kid things. So yes, we want to help them when they're older, but it starts early. Really emphasizing maintenance of that lean muscle mass we can. The other thing that's going to get us into trouble with lean body mass is I think we're also seeing a generation of diet triers. Everyone's going up and down, trying to lose weight, they gain weight, lose weight, gain weight. Every time they go through that process, they're losing lean muscle mass and then regaining fat mass. So the more that ratio gets thrown off, the more apt they are to gain more weight, and you don't have that lean muscle mass to burn fuel, to keep you strong, to keep your balance, to protect your bones. The aerobic activity is not sufficient enough to stop these losses. The aerobic activity is important. Yes, we want to get our patients out walking, jogging, biking, whatever we can. We have to also emphasize that resistance training, especially in women. We need to get them out doing planks, crunches, easy stuff at home, soup cans, doing biceps and triceps. Little things make a big difference. The other thing we need to make sure we're incorporating when we talk to them is this balance and flexibility. Keeping them flexible, keeping them balanced helps them with their ADLs as they get older. But this all comes back to a good core strengthening, good lean muscle mass. Just adding in resistance training can improve their strength from 40 to 150%. That's a huge impact we can make in our patients by asking them to make a change 2 times out of the week. I know we live in a society where time is limited. We need to be able to help counsel our patients on where to find that time and explaining to them how big an impact it can make in them. So again, we get to wanting to increase that muscle mass. The endurance training is important because we want to maintain that aerobic capacity, but walking isn't enough. It's not going to keep muscle strength. There's an interesting study that came out a few months ago, I don't know if anybody saw it, that talked about your pace of walking was indicative of your overall health. So the pace at which you have your patients walk is important. 100 steps per minute correlated to better cardiac health, better lean muscle mass. So if you have, I joke around, my husband's from Maryland, I'm from Ohio originally, and we got down here and we were like, everyone walks so slow. So get our southern patients up and moving, and it actually will help them just to tell them to walk a little bit quicker. It'll improve that overall health. But adding in that progressive resistance training has the potential to decrease the risk of diabetes, decrease the risk of falls and fractures, decrease the disuse that we're seeing in these patients, that frailty. And it's hard. Patients have genetics stacked against them. They have chronic disease factors stacked against them, but at the same time, they have control over their lifestyle. I know it can feel overwhelming when patients get into that conversation, but they're the ones in charge. I think a lot of them come in to see me from an arthritis standpoint, and we have long conversations about getting moving and how that's going to help them long term, and that weight reduction, even by a 5% amount, will decrease their pain by 50%. And there's great data to say that. And you get pushback. I just keep repeating it until we have this open conversation about how important their lifestyle is to their long-term health. So we're looking at how best to approach it. If we want to burn fat, we want to decrease that total body adipose tissue. We want to incorporate aerobic and resistance training. Energy restricted diets can help, but it's got to be focusing more on healthy eating than restrictive eating, because patients will only do restricted eating for a period of time, and everyone in the sports medicine community loves to say we can't outrun a bad diet. You'll see a lot of people who are over-exercising, training, trying to just make up for what they did the day before. So talking to your patients about eating to live instead of that, just withholding food from them. And I look forward to hearing what we have to say about nutrition after this. And it's hard to get visceral fat mobilized. Patients aren't necessarily going to see the body response as they're aging that they want to see, but encourage them that their overall health is the important factor here. And it's hard. Most of my patients that I see outside of my athletic college 18 to 20-year-olds who make me feel terrible about myself because they are fit and trim and all I get exposed to. These patients come in pain. They come in anxious. They come in depressed, and it's such a vicious cycle from a physical and a psychological component. They hurt, so they don't do activity. They decondition. They hurt more because they're not doing anything, and then they're coming back, further avoiding that activity and further avoiding the recommendations you make about moving, and they hurt more. At some point, we've got to intervene and break that cycle, and just masking their pain with pain medicines is not the answer. We need to educate them on how important moving is to treat their pain. I had the luxury of training under an orthopedic surgeon in the upstate he said the same thing over and over at every patient. I felt like I heard each one about 300 times a day. And I've now heard my fellows over the past few years saying those same things. I realize I'm saying that an awful lot. But I can't tell my patients enough, motion is lotion. Move. I know it hurts. I know you get up from your chair, you're stiff, your knees ache. Get moving. Stay moving. The more you move, the more the joints are lubricated, the better you're going to feel going forward. And a lot of them just need to hear that it's okay to hurt. You know, somebody along the way told them, oh, if it hurts, don't do it. So they've wrapped their arms around that and they stop being active. They don't get up out of their chair because it's going to hurt and it's not okay. It is okay. Just kind of get through it. And they just sometimes need your hand holding to help them make that. So we know Exercise is a prevention. It's great. Patients are going to suffer from genetic, environmental factors that lead to their disease pathology, but chronic illness related to behavior and patterns of physical activity change is just about every chronic disease we're facing outside of your degenerative neurologic diseases. Even dementia can benefit from physical activity. So don't let any of your patients with any of their diseases limit you from having that conversation. Just understand where you're going to have to modify things for them. We know hypertensive patients, and I'm sure you talk to your patients about this all the time. You can lower pressure in active individuals 5 to 10 millimeters of mercury. Depending on their type of intensity, you can get more. And your greater training effect happens with those mild to moderate hypertensives. Maybe start with lifestyle changes and talking about physical activity first before medications. It's not always going to be the answer, but it's still an important conversation to have. We know vascular disease, peripheral and cardiac, benefits from that exercise training. You're going to reduce their claudication pain, you're going to give them greater walking distance, you're going to improve their functional endpoints, and it's going to benefit a lot of patients with that coronary artery disease component. So from an arthritis standpoint, and this is what I focus on with my patients, the majority of my aging population I'm going to see in an orthopedic clinic, and they've been sent to me by the orthopedist or a family physician in the community who MRI'd them because they had medial joint line pain, and they have a degenerative meniscus, and they've got all this arthritis, and the surgeon, they're finally coming off that curve of scoping everybody to clean up their knee, which is not the right thing to do. And they just say, oh, go see Dr. Murphy, she's gonna fix your knee, which I appreciate the importance that our orthopedic surgeons give me in treating their arthritis, but a lot of it's talking to them about just getting moving and how that exercise is going to improve their functional status. It'll give them a faster gait, just moving. It's gonna lower their depression. If you look at your arthritic patients, their depressive score is gonna go up because they are limiting their activity, they're limiting their lifestyle just based on this one symptom. They hurt, they've been told it's gonna make it worse, they're afraid to do anything. So they become depressed and isolated and lose out on what's going around them in their lives. But less pain, less medication use, trying to educate patients that, you know, even an anti-inflammatory, or they don't need that all the time. I like to tell them to use it in shorter bursts for that scheduled time, 2 to 3 days at a time, and then take a break. Getting up and moving has proven they're going to reduce that amount that they use. And the strength and endurance training benefit that you can provide them with physical activity is going to do nothing but give them protection of bone health. The mental health aspect, and I know you guys touched about this a little bit earlier, we know that exercise is often a neglected intervention because everyone's spread out. There's a shortage of psychiatrists. Their time's demanded. They're writing prescriptions. It's hard to get into a counselor. So how many people are actually telling these patients, you need to exercise, that is actually going to help improve your outcome, especially in older patients? You know, as patients get older, we're trying to pare down their medication list and not have them on so many things so they're not running the risk of polypharmacy. When we could add this one medication of exercise and maybe limit putting them on other pills. If you look at the study by Blumenthal, exercise was comparable to antidepressants, especially in the aging population with major depressive disorder. So use it as a treatment. Patients showed improved sleep, increased interest in sex, better endurance, stress relief, improvement in mood, increased energy and stamina, reduced tiredness that can increase that mental alertness. This really needs emphasized and reinforced by all of our medical team around our patients. Runner's high is real. It is amazing how once a patient gets moving, and it's not just running, it's exercise. And once they get moving, how it just becomes a part of their routine because they do feel so good mentally and physically. I mean, it's not about the external outward appearance changes that, you know, society wants to throw at us. There really is chemically stuff going on in their brains that's going to benefit them. Meditation and running have the same effect on the brain. So if somebody says, I don't want to meditate, I'm not that, that's not going to work for me, just go out and jog, go out and walk, go out and bike, something, get moving. It engages your executive functions and helps kind of turn out that white noise. And I think the white noise is the majority of what our patients are having to deal with, with everything going on in our society at this time. Now, there's some patients you're going to have to talk to about, can you exercise, can you not exercise? There's relative risks, obviously any acute illness, undiagnosed chest pain, diabetes, hypertension, asthma, CHF that's not controlled, you're going to have to modify your recommendations or get them plugged in with cardiac rehab or physical therapists who can help monitor them while they're starting an exercise program. That's one of the things I really like to do in the community I am, is get to know the physical therapists, the cardiac rehab, your performance offices, to know who is good with certain patient populations so you have recommendations to give your patient. Because a lot of times patients don't want to start working out because they don't know what to go do. The more specific we can be with our recommendations, or the more we can offer getting them plugged into an office that can help them get started. Patients will push back saying, well, I don't want to pay for a bunch of visits. Go one time. Get started with the physical therapist one time. They'll give you a home exercise program. If we need to do a check-in at 6 or 8 weeks, that's a great way to approach it and just getting them moving. Obviously, there's absolute contraindications, an inoperable aortic aneurysm, cerebral malignant ventricular arrhythmias, aortic stenosis, end-stage CHF. It's going to be a different conversation with these patients. So how do you get started for the patients who you have these conversations with? The first thing is, what does the patient want? What do they need? What do they enjoy doing? This takes time. This takes getting to know your patients, but you're going to get better results if you have these conversations. And then understanding, do they have any cardiac risk factors? Do they have any orthopedic risk factors that you're going to need to address? The cardiac risk factors we talk about, hypertension if they're on beta blockers, because obviously that's going to blunt their response. Hyperlipidemia, smoking, diabetes, that risk of hypoglycemia with exercise. And then from an orthopedic, are they susceptible to injury? Is this somebody who, if you get them running, they're going to end up with a stress reaction because of thinner bones, osteopenia, osteoporosis? Are they able to do high intensity resistance or high impact aerobics? So we break those down. 0 to 1 risk factor, they're healthy. You don't need to do anything further. Just help outside of helping them structure a routine. Higher risk, 2 or more risk factors, you're going to obviously do a little bit more of a workup before you make recommendations from an exercise standpoint. And then same thing with anybody with cardiac or pulmonary or metabolic disease, you're going to have to really align your recommendations with having done the proper workup, making sure everything's stable. So I don't know how many of you get on treadmills or ellipticals, and there's that little disclaimer at the bottom, and it says, if you're starting a new workout regimen, please contact your physician. So we get people all the time who ask, do I need an exercise stress test? If they're high risk, if they have known cardiac disease, yeah, I would do one. There's good data, but generally for patients starting a new physical activity regimen, no, they don't. They put that on there because somebody sued that company at one point in time. They really just need your guidance in getting started and support. So how do we write an exercise prescription? Obviously, we have to think about the modes we're going to recommend. General activities we can give to patients. I like to say, if it's somebody who tells me I don't like walking, I don't like running, I try and get them out doing yard work to start with. Little things that you can incorporate into their daily routine. But think about all the general activities they do in their life that you could maybe build upon to prescribe. And then make sure you're talking to them about aerobic, resistance, and balance. Now, you're not going to want to start all of these at the same time. I would get them started with something aerobic, and once we're moving forward with the aerobic, then we add in the resistance, and then once we're comfortable with resistance, I add in the balance. But from a balance standpoint, wanting to do a risk assessment, making sure they're not somebody who, as they're getting older, you're worried about falls, and fractures. So things the mode is governed by: duration, minimum of 30 minutes. And it doesn't mean you have to go out and do a 30-minute sprint down the road. It's trying to get 30 minutes cumulative during the day. 30 minutes in a 24-hour time period should be very doable, no matter what your patient tells you. And they will come up with all kinds of excuses. It's amazing. And frequency, most days. I would say 6 days a week. If we can get our patients, ideally 7, trying to mix it up if they're doing resistance training 2 days out of the week and aerobic training 5 days out of the week, you're covered. Now we go back to intensity, and the best benefit from this age range as we're getting older is that 55 to 75% of max heart rate, so that 220 minus your age. And I don't tell these patients they need to wear heart rate monitors or anything like that. They can go by that perceived exertion scale. If they feel like they're working hard, they're probably working hard. So we think about the basic recommendations we just said, that 30 minutes a day. It's 150 minutes in a week. 90% of our patients are not meeting this goal. 90%. Think of the implications of just getting a handful of your patients moving is going to have on that statistic. As physicians, we need to do a better job of this. Instead of getting pain scales from patients as our next vital sign, maybe we should be doing exercise intakes. Add it into your intake form in the waiting room. Just ask, are you doing any kind of exercise? What are you doing? How long do you think you're doing it for? Just to help them build that into their habit. So if you go to American College of Sports Medicine, you would think that they'd have great specific guidelines. This is what you get. So even our governing bodies aren't giving us great tools to help our patients. I think it's something we're as physicians going to have to push ourselves. But they give you that 3 to 5 days each week, warm up 10 to 15 minutes before you do aerobic activity, good intensity for about 30 to 45 minutes, and then a cool down 10 to 15. If you want weight loss, obviously 30 minutes, minimum 5 days a week at that 150 per week. I think we need to be more structured in what we're telling our patients. If you just tell your patient, go do 30 minutes a day for 5 days a week, how many of you think they're going to actually do that? 0. I have a hard time getting my child to do something for 30 minutes, 5 days a week if I just told her to do that. If you dig a little deeper, there's this active aging website. If you want some more information, it just talks about five ways to eat better, 5 ways to increase eating pleasure, 5 ways to eat well. 5 steps to begin endurance exercise. These are good tools to build on to help have information to give to your patients. But I would work on reaching out past ACSM and looking at what's available in your community so you can specifically give your patients recommendations. So how do I start with my patients? I keep it simple. I give my spiel to my patient why I think it's going to be beneficial, the benefits in weight reduction to their pain, because I specifically deal with arthritic patients and trying to focus on pain reduction. But telling them, just get up, get 30 minutes during the day. It's easy as 5 minutes in the morning, before you leave for work or before you get going for the day, 5-minute walk around the block, park far away from your office, try and get 10 minutes in at lunch. When you get home after dinner, 15 minutes, that cumulative effect gives you the same benefit. And I emphasize this to my arthritic patients because a lot of them will tell me, I used to walk 5 miles a day, or I used to get out and do this for an hour a day. I'm like, that's okay, that total. If you're hurting after that, the best thing we can do is let's break that up during the day. I still want you to reach that goal, and it's okay to do that much. But maybe you do a mile before breakfast, a mile at lunch, and a mile after dinner. Trying to help them, once you've hit on what they like to do, or if they've told you something they miss doing, try and find a way to help them incorporate that back into their routine. But again, trying to add that strength, that flexibility component as well, especially in our aging population. If they push back on your initial recommendations, ask them, what do you enjoy? Do you want this to be social? Will you meet your friends if you go do something? I find this interesting. My parents, they live in a community on the coast, and all the ladies go and do water aerobics. But they go because it's social, but they're getting exactly what they need. So if it's something where they can find it's in the community or their friends are doing it, encourage them to go. And again, I think people are afraid because they think everyone else is judging them. But everyone's feeling that way, and just be there as a support system to reassure them of that. Again, where they park at work, taking a couple extra flights of stairs, little changes that they can make throughout the day. The interesting thing is when you look at our physical labor workforce, I think everyone expects them to be healthier because look, they're out working all day. They're not the sedentary desk workers. They're actually suffering from more chronic disease, more cardiac issues than our quote unquote desk workers. Part of that is, although they're physically laboring, they're not reaching that aerobic threshold to gain any benefit from a cardiac standpoint. The other aspect to that is they're so fatigued from working all day physically, they're not adding in any extra cardiac aerobic work. So they may be getting the strength component from what they do physically at work, but they're not actually doing anything to benefit their long-term health. So if this is a part of your patient population, really work with them to help them find ways during their day because they are an at-risk population. Again, start small. If it's somebody who pushes back on the 30 minutes, I try and talk to them about just adding 5 minutes gradually. If they can do 5 minutes for a week, 5 days out of that week, we add in and do 10 minutes the following week. It's as soon as they start carving out a little bit, they can start carving out a little bit more and carving out a little bit more. And have quick follow-up with these patients. Somebody needs to help them from an accountability standpoint. So don't say, well, let's try this and I'll see you 6 or 8 weeks. Bring them back regularly, check in on them, or have your nurse make a quick phone call just to say, hey, did you meet your goals this week? It's really effective. The data has shown good communication, good follow-up does help with outcomes. So we've gotten their cardiovascular fitness met. Then I try and add in this stretching, strengthening. I like to recommend yoga, Pilates. They can do this at home. There's a million YouTube videos if you look at yoga and aging. Because a lot of these things they don't want to do in a group, and I get it. I've got my mom doing yoga at home. She does it 30 minutes a day. She calls me and tells me I'm crazy, and I said, but look, your bone health is that much greater. And then add in strengthening. Again, they can do this at home. Just give them a quick sit-ups, planks, side planks, crunches. Push-ups don't have to be military-style push-ups. Get them on their knees or get them against a bed so they're at a 45-degree angle, doing push-ups that way. As we get older, obviously our strength isn't as great. We're going to have to make modifications, but being able to give them guidance in that is going to help them succeed. And try and get them up to twice per week. The other things we want to consider are other impairments from medical issues. I put this up here. I have a lot of patients who have ostomies, and one of the things we've come across is what's called a stealth belt. And you can swim in it, you can surf in it, you can work out in it, and you'd never even know they have an ostomy. But knowing ways you can help accommodate your patients is going to set your patients up for success. Vision, hearing impaired patients are going to need obvious accommodations, and understanding environmental issues. Down here, we're going to have to talk to them about going earlier in the day or later at night in the summer, so we're not talking about heat illness in our elderly population. Just be mindful of the world around them. So exercising and osteoarthritis, one of the reasons I really wanted to touch on this is it affects over 30 million people in our country, and I see a ton of it on a daily basis, and the last thing these patients want to hear is deal with it. It's a little bit of the conversation that we have to have. It's not a normal part of aging, but it happens as we age, in the majority of us. And it's very disabling, especially in developed countries. We're seeing more and more long-term disability from osteoarthritis at a young age. I'm talking 40s. I have patients come in and, can you fill out disability paperwork? Let's see what else we can do first. And part of that's the obesity problem. Again, kind of starting back with treating your patients young, getting them moving. But it's an economic impact on our healthcare system that's just draining. So how are we treating this? I think corticosteroid injections is what we've all done and all seen for years, alongside the arthroscopic cleaning up of degenerative meniscus and arthritis, and that's not necessarily the best pathway for these patients. Yes, I still do steroid injections. I do them sparingly. We know, study came out last year looking at multiple injections within a 2-year time period showed significant articular cartilage loss compared to patients who weren't receiving injections. So there is risk putting steroid in the knee every time we do it. Now, if I have a patient who comes in every 5 years for one and they do great with it, yes, but I'm not just going to give somebody a steroid every 3 months until they pass on just to keep them comfortable, because I'm putting them at jeopardy by going that route. Same thing with scoping them. So what else do we have to offer? Viscosupplementation is a great option. It's a hyaluronic acid component that kind of mimics the articular cartilage. We're not necessarily doing any healing. We're not doing any rebuilding of articular cartilage, but we're giving that cushion, that lubrication to keep them moving. Depending on which brand you go with, it can be one injection, it can be a series of 4, and it builds over time. And patients generally get about a year of significant relief, year to 3 years of moderate relief, depending where they are in their course. The big thing I think you're going to hear a lot about over the next few years is regenerative medicine, and that's platelet-rich plasma injections, or PRP. It's stem cell therapy. The biggest battle we're fighting as a specialty right now is it's not FDA approved. So patients are paying anywhere from $350 to $650 across the country for PRP, which is we draw off some of their blood, we spin it out in the centrifuge, you get that thin layer of platelet-rich plasma, and we're re-injecting it under ultrasound guidance into the joint. The next step up would be that stem cell therapy. In your older patients is going to be adipose-driven. So you're actually taking about 60 cc's of adipose tissue from their belly, spinning it down to get that stem cell layer, and then re-injecting it into their joint. You're looking at anywhere from $3,000 to $10,000, depending where you go in the country. If you do 2 joints at once, usually we can do it a little bit cheaper because it's one kit to actually draw off all the adipose tissue. But there's great data from European studies about significant improvement in osteoarthritic pain with this process. So what I tell my patients is, if we haven't reached that point from an age standpoint that joint replacement is the right path for you, let's talk about stem cell, let's talk about PRP, because my operating philosophy, and if you talk to a lot of the surgeons around the country, it's going to be, you want to hold on to your body parts as long as you can. Joint replacement surgery is not the end-all be-all, and it's definitely not perfect. So I really try and have a long conversation about regenerative medicine with our patients and going over the literature, and there is good outcomes when we look globally at what's being done. Now, getting the US FDA on board for stem cell, I don't know what that's going to take. I will continue to fight that battle for my patients, but consider it. Don't just MRI your patient, see some arthritis, send an orthopedic surgeon, talk about joint replacement. There are alternatives that we're looking at. Bracing, there's medial, there's lateral unloading braces trying to open up that joint space to give them less compression on the joint. I like these for patients to have them for that day they need it. If they have a terrible, horrible day of being on their feet, or they're traveling and they're afraid they're gonna be doing a lot of walking, a lot of steps, they have it with them. What I found is too many patients are given an unloading brace by their surgeon, and they get to me and then they have 0 quad strength. And if you have bad bones and now you've taken away the muscle strength around it, you don't have anything working around that knee. So don't just jump to giving your patients a brace, giving them support. You're actually kind of undermining the idea of keeping the muscles strong around the bones to protect them. And it's funny because most patients come in to an orthopedic office and they're like, well, I need a brace. That's the first thing they say, second after they say I need an MRI. Neither of which do we need to jump to. So just keep it, it's an option, but really make sure you've educated your patient on how you're using it. And medication is the same thing. There's time and place for it, and it's useful. NSAIDs work better if they're scheduled, but I don't like patients to just take them and use them over prolonged periods of time. I like to say schedule it for about 3 or 4 days if you've had a rough stretch, then take a few days off, and then schedule it for 3 or 4 days. And patients do well with that, and we're not then adding into the hypertensive and the renal risks and the GI bleeding risks that we worry about. And then the bottom one, I cannot emphasize enough. It's interesting because I spend all my time in an orthopedic office, and the orthopedists love to tell me, think like a sports medicine physician, not a primary care provider. Not everything's fixed by physical therapy. And I keep going back to them and saying, have you not read every journal article in the last 5 years that talks about how great physical therapy is? And the studies prove it. Get your patients moving. If the physical therapy office will help them get moving from an exercise standpoint, from an arthritis standpoint, use it. Now, not every physical therapy office is created the same. So go out, take the time to get to know the therapists in your community. They love talking to physicians. When you get that two-way interaction with them to really discuss a patient and break down what they need, the outcome is that much better. And they love it. They love nothing more than hearing from us. Again, degenerative meniscal tears, it's really important that I emphasize this. The study that came out last year looked at 3-month outcomes after scoping compared to non-operative management. There was no difference at 3 months. At 2 years, better outcomes with non-operative management versus scopes. So don't just rush your patients off to see an orthopedist thinking they need a scope. Multiple studies have demonstrated the importance of physical therapy exercise for long-term pain relief. And this is a conversation I love to have with patients, because right now patients have kind of passed down to each other, I just need to go get my knee cleaned up. And when you start talking to them about how getting moving will actually be more beneficial to them, as opposed to their thought process is, if I move, I'm going to hurt something worse. No, you're not. Encourage them. Support them, get moving. You're not going to hurt anything. It may hurt, but you're not damaging anything. I do like to get them biking or swimming if I can, just to help from a repetitive pain response that they go through. There's a lot of aquatic-based physical therapy offices. You'll see them more and more where they can offer this to get them started. Water aerobics and water resistance training are just as efficient for improvement in cardiorespiratory, or that aerobic response. And it's great for development of knee flexion extension, so we're not losing that range of motion. So I assess this at every visit. So I want to know from the beginning, what are you doing, how much are you moving? And if you make it a priority to ask them, every time they're going to make a priority, because they don't want to tell you they haven't been thinking about it. So if they know you care, they're going to care. So ask them where they're at, be able to offer just one recommendation, a small change at each visit, and just keep reminding them of the importance that exercise is going to play and making it a priority for them. If you had one medication you could give a patient that offered 20 aspects of their health and their life that it would improve, I would imagine you would give that medicine to everyone. That's exercise. So I like to tell my patients, if exercise were a pill, I would be writing a prescription for every patient. Just encourage them, get them moving, get your young ones moving, but get your old ones moving. So, thank you.
Questions? Hey, hide mine.
So I'm curious about the kind of resistance exercise. Say you have somebody who's 75 years old, comes in and says, oh, I'm having a little trouble. I don't get up off the toilet as easily as I did before. I can't walk upstairs as well. They have proximal muscle weakness.
Yeah.
So what kind of exercise would you start? I mean, these people are not, runners.
No. That's the patient I would tell them, find a chair to sit in so you're safe, because obviously we don't want to create any falls, we don't recreate any or injury risk. And I would either have them take, 3-pound dumbbells if they can buy them, or the resistance bands that they can tie to a doorknob or a bedpost or a soup can, and literally just bicep, tricep, overhead extension. Just those 3 alone is going to help improve that shoulder girdle, but it's also going to give rotator cuff stability as well. So little things.
Like you think start out with 3 pounds? You think?
Yeah, 3 pounds is sufficient. I mean, especially you're talking 70, 80-year-old patients, 3 pounds is more than enough. They're getting something against gravity. And I start with those 3 exercises and tell them do 10 of each of them 3 times and start there.